Thank you very much. I'm going to talk on managing resistant hypertension. As we all know, the diagnosis of resistant hypertension is made when patients take three antihypertensive drugs with complementary mechanism of action, one being a diuretic, and still do not achieve control, or when the BP control is achieved with more than four medications, equal to or four medications. So that's the standard definition of resistant hypertension. Now, we talk of resistant hypertension, we must be careful that we exclude patients with pseudo-resistant hypertension. And pseudo-resistant hypertension, there's a significant people who have white coat hypertension and they can be detected by ABPM. And then, of course, there's pseudo-hypertension because of non-adherence and therefore pill counting, multiple drug, single tablet combination therapy. So non-adherence, in my opinion, is a very strong reason for resistant hypertension. Then, of course, there are truly resistant hypertensions in which you must find secondary causes, because this is the group where you'll find secondary causes, unlike those patients who you see in your day-to-day practice. So it's important to look at these. Refractory hypertension, malignant hypertension, I think is going to be discussed later. Now, when you approach a patient with resistant hypertension, you must establish true resistant hypertension. Is the BP being monitored accurately? You have to rule out white coat hypertension. You have to consider pseudo-resistance, and you have to consider secondary causes. So that's the way we need to approach it. When you talk of pseudo-hypertension, non-adherence, as I mentioned, is the most common cause. Inadequate regime, that means not giving adequate dose. You may give three tablets, three drugs, but you might not give adequate dosage, and that cannot be therefore considered as resistant hypertension. And of course, you have all these interfering NSAIDs, etc., which might worsen the problem. Then, of course, you have pseudo-hypertension, where the arteries are very calcified and not easily occluded by your BP cuff, and therefore you get severe hypertension when you monitor, but no end organ damage. And when you treat them with antihypertensive drugs, they often get worse. So clearly, you should look out for this group of sort of pseudo-hypertension. Once you think that this patient has hypertension, you must rule out secondary causes. The most common one is the parenchymal renal disease. We know what investigations to do. Then, of course, we have to look at renal stenosis, renal artery stenosis, which may be atherosclerotic or fibromuscular dysplasia. And most important, don't forget sleep apnea as a very common cause of resistant hypertension. So this must be looked for in all our patients who have resistant hypertension. Then, of course, we have to look at high aldosterone states. There may be primary aldosteronism, which may be an adrenal adenoma or a bilateral adrenal hyperplasia. We need to investigate that by looking at the aldosterone-renin ratios. Then you have to look at secondary hyperaldosteronism, maybe a secreting tumor. Renal artery stenosis can produce secondary hyperaldosteronism. And then, of course, you look at glucocorticoid metabolism, Cushing syndrome, and congenital hyperplasia. So these are some of the important secondary causes that we need to look at. Of course, we look at other things like Liddle syndrome, and of course, pheochromocytoma, another thing which may be missed. And they say that the average period is almost 3 years before a resistant hypertension is diagnosed as pheochromocytoma. Doing plasma-free metanephrines and urinary metanephrines and catecholamines will give you an answer to this problem. Or, of course, a CT scan looking at the suprarenal mass. Don't forget simple things like aortic aortation or aortic syndromes, where simply examining the patient's all four pulses will give you a diagnosis. So all four pulses examination, go back even if the patient's been on treatment for long. So again, look out for primary aldosteronism, renin, angiotensin, plasma renin, serum aldosterone ratio is very important. And then, of course, for pheochromocytoma, as I mentioned, you have to measure the metanephrine. So these are the two common things which we need to rule out in all patients which are hypertensive resistant. Then, of course, when we look at patients' treatment, we have to optimize the three-drug regime. So though we say resistant hypertension is those who do not respond to three drugs, it's important what three drugs you choose. If you choose three random wrong drugs, or if you give inadequate doses, then you can't call this patient really a resistant hypertension. And then, of course, choosing the fourth or fifth agent as may be required. Now, we all know that this is the most widely used combination of first choice. It's either an ACE or an ARB, along with the calcium channel blocker, dihydropyridamine. And there are so many calcium channel blockers now, multiple new ones with other benefits in terms of C-type and T-type, benefits on the kidney, single dose. So I think all this needs to be taken into consideration as well. And then, of course, you should have a thiazide light diuretic like indapamide or clothalidone, which, as we know, has been shown to be better than a thiazide. So clearly, this would probably form the basis of any patient who's got resistant hypertension, a single tablet combination of these three drugs, because you want to keep the adherence in control, and therefore you want to reduce the pill burden. So this three combination, in my opinion, will probably form the basis of any treatment of resistant hypertension. Then, of course, you have to add the fourth drug, and we know there's a lot of benefit of spironolactone being added to that. As we can see that spironolactone produces a significant reduction of blood pressure. It's a dual renin-angiotensin-aldosterone blockers with offered by spironolactone is beneficial. You can of course start with a small dose and gradually build it up, even up to 100 milligrams if necessary. We also know from previous data that spironolactone has benefit in terms of endothelial dysfunction, and this can be a further beneficial effect of aldosterone antagonists. Don't forget, in males particularly who have gynecomastia or women who develop menstrual problems with aldosterone antagonist spironolactone, you can safely use eplerenone, which will have much less side effects compared to spironolactone. Then, of course, we have to think of other fourth drugs because the patient is not responding to your first three drugs. You can use vasodilators like hydralazine. I think it's a pretty effective drug in my opinion. Then you certainly could consider the addition of hydralazine. I've not mentioned beta blockers here, but beta blockers also, in my opinion, are extremely important when you're talking of resistant hypertension. And I think another combination of a beta blocker with hydralazine as a second combination in the evening, along with the first combination that I mentioned. So I think a beta blocker hydralazine combination will be a very optimal combination. Then, of course, we have centrally acting drugs, of which moxidecine is the most useful today. But again, benefits of these are very variable. Alpha blockers are very commonly used in resistant hypertension as a fourth drug, and these are particularly useful for patients with renal dysfunction because they don't affect the creatinine and they don't affect the potassium, which many of these other drugs might do. So clearly, we have an option, and I think we have to individualize patients. We also know that treatment of resistant hypertension, there's a big role of the sympathetic nervous system. And I think therefore drugs like clonidine, which of course is not used, moxidecine, which has become a very favorite drug as a fourth or fifth drug in patients with resistant hypertension. And I personally believe that beta blockers are extremely important and should be continued to use, especially in those with high sympathetic turn, especially those who got hypertension and high heart rate. I think controlling heart rate is also an equally important factor. Now, again, in order to maintain compliance, as I mentioned, it's very important to use a single pill combination. So if you're going to use 5 or 6 drugs for severe resistant hypertension, patient will not take 6 drugs a day. So the best thing to do is to give a combination of 3 tablets in the morning, means 3 drugs in one single tablet in the morning, and in the evening, a combination of either 2 or 3 drugs in one single tablet. So with 2 drugs, one morning and one evening, you should be able to control most of these patients. Again, there is a question of administration. We all know that RAS blockers are better in the evening. We all know that those who are not dippers and who got a rise of morning blood pressure, better to give them an evening dose. So again, you can take one of the combination pill and give it at night or in the late evening, and one in the morning, particularly with the diuretic. So you can split the drugs in order to get better compliance and in order to get better effects, especially in those who got nocturnal hypertension. Then, of course, if the patient doesn't respond to any medical therapy, then you have to do intervention. We can do renal intervention. We can do renal artery stenosis, stenting, and carotid sinus stimulation. I'm not going to talk more on this because this is going to be extensively discussed in the next few talks. So to quickly summarize, if you have a patient with resistant hypertension, first you confirm that this is really a treatment resistance and not other factors like pseudo-hypertension, etc. Once you rule that out and you know that it's a true hypertension, look for secondary causes, of which don't forget primary aldosteronism, Cushing syndrome, coarctation of the aorta, and pheochromocytoma. Then you assess for target organ damage and try and reduce the target organ damage. When therapy is concerned, of course, the overall lifestyle manifestation is extremely important. It must be a first part of your thing: exercise, weight loss, salt restriction. Combination of 3 drugs, which I said best being RAS blocker, calcium channel, and diuretic. Second channel, maybe you should use, I would not use this as a second step. I would say right from the beginning, use chlorthalidone or indapamide. Then, of course, you add your spironolactone or eplerenone. If the patient is still not controlled, then, of course, again, as I mentioned, beta blockers, in my opinion, are still important, particularly in those who got high heart rates as well. Hydralazine can add on or be combined with beta blockers and hydralazine. Minoxidil we don't use here. I think much more frequent we use moxidecine or an alpha receptor blocker like prazosin. So a single combination treatment in the morning of ARBS, indapamide, and calcium channel blocker, and in the evening either beta blocker hydralazine or a moxidecine or a prazosin. So these combinations would therefore control most of the patients, and we have to make sure that we prevent resistant hypertension from going into malignant hypertension, which is also going to be discussed very shortly. So thank you very much indeed.